Welcome everyone to Health for the World International Grand Rounds. We are honored to have our Grand Rounds speaker today, Dr. Sherry Wang. Dr. Sherry Wang is an assistant professor of abdominal imaging at University of Utah. She is a renowned abdominal radiologist, and I would encourage everyone to check out her YouTube channel, which features really important educational content which everybody will find very helpful. She also does education via Twitter, and you can follow her on Dr. Sherry Wong. Dr. Wong did her fellowship at University of Washington in body imaging. She did her residency at Liverpool Hospital and was an advanced MRI trainee and registrar there. She did her residency at Alfred Hospital in radiology. And at Royal North Shore Hospital, she did her general clinical rotations. Um, she did a medical degree from University of New South Wales Faculty of Medicine. Dr. Wong is a renowned abdominal radiologist who is very passionate about education, and we are really honored to have Dr. Wong today to talk about an important topic, which is the imaging of gastrointestinal bleeding. So on that note, we'll start right now. And thank you so much, Dr. Wong, for helping us. And Dr. Wong also leads Health for the World University of Utah chapter and has really done an inspiring work during her leadership. So we really appreciate this. Thank you, Dr. Wong, and you can start whenever you're ready.
Hi everyone, so I'm Cherie and today I'm going to be talking about imaging of the gastrointestinal bleeding. So as full disclosure, I chose this topic because this was something that was very confusing and challenging for me as a radiology resident. And honestly, these were not my favorite studies to read. So I hope this lecture can help those who find this topic challenging and embrace. I won't go as far as to say love reading these studies. So the only disclosure I have is that I received book royalties from Elsevier. And I would like to give acknowledgements to Dr. Arafat Ali from the University of Cincinnati and Dr. Jonathan Revels from the University of New Mexico. So these are our objectives for today. We want to understand how gastrointestinal bleeding can be imaged using different modalities. We want to explain the CT protocols used in cases of suspected gastrointestinal bleeding. And I want to illustrate the main radiological signs to identify the presence of bleeding, its source, and its cause. And I would like to highlight the major pitfalls of CT in the evaluation of gastrointestinal bleeding. So firstly, gastrointestinal bleeding is a serious clinical problem. It's actually the leading GI disease related cause of hospitalization in the United States. GI bleeding can be divided up by where the location of the bleed is. And the location is very important as it changes management and the associated prognosis. The location for GI bleed are upper GI bleed, lower GI bleed, and small bowel bleeding. In the treatment of GI bleeding, a multidisciplinary approach is needed. And the evaluation of location of bleeding and etiology is important for selection of best therapeutic approach. So non-invasive imaging techniques, especially CT, are now heavily utilized in the evaluation of GI bleeding. So upper GI bleed is defined as bleeding proximal to the ligament of Treitz. Upper GI bleed is more frequent compared to lower GI bleed, with the incidence of 100 to 200 cases per 100,000 persons annually. Upper GI bleed accounts for over 300,000 hospitalizations each year, with a mortality ranging between 3.5 to 10%. In the clinical setting, the patient may present with hematemesis. This can be ground glass or frank blood. They can also present with melena. Nasogastric lavage can be performed in the clinical setting to assess for blood in the stomach. However, when this is negative, it does not exclude upper GI bleed if the source is distal to the pylorus. Now let's move on to lower GI bleed. It is defined as bleeding from the rectum or colon, and the incidence of lower GI bleed is 20.5 to 27 cases per 100,000 persons annually. The mortality of lower GI bleed is lower than that of upper GI bleed, and it ranges between 2 to 4%. And this difference is due to the limiting nature of lower GI bleed, which spontaneously resolves in up to 80 to 85% of cases where only supportive measures are needed. Patient presents with hematochezia. They can also present with melena if the bleeding source is from the cecum or the ascending colon. So small bowel bleeding can be a real clinical dilemma for the clinicians we work with. And it is defined as bleeding that is not classified as either upper or GI or lower GI bleed. And this is usually given, this diagnosis is usually given when the upper and lower GI tracts have been assessed and no bleeding source was found. So clinically overt means visible blood. So this is your hematemesis, hematochezia, and melena. In occult bleeding, that is bleeding that cannot be visualized, but the patients may have a positive fecal test or the patient may be experiencing anemia. This is just a table that kind of organizes what are the potential causes of upper and lower GI bleed. So in upper GI bleed, we have things like peptic ulcer disease. So this could be duodenal or gastric. Esophageal lesions due to reflux. So esophagitis and esophageal ulcers are something that's more common. Portal hypertension is an entity that can cause upper GI bleed through esophageal and gastric varices, as well as hypertensive gastropathy. Now, moving on, there's also tumors that we have to think about. And in the upper GI system, we have adenocarcinomas and GISTs. Other things that are not as common are things like aortoenteric fistula, Delafoy lesion, hemobilia. Now let's move on to some of the entities causing lower GI bleed. So tumor is going to be very high up there, especially in an older population. So colonic adenocarcinoma is a frequent cause of slow kind of chronic bleeding. Inflammatory and infectious causes such as inflammatory bowel disease and colonic diverticulitis and vasculitis can also be a source of bleeding in the lower GI system. Vascular include angiodysplasias, ischemic colitis, and hemorrhoids, which we may not see on our imaging. And other things to keep in mind are colonic diverticulosis and endometriosis can also be a source of bleeding. So firstly, we're going to go through the American College of Radiology appropriateness guidelines because I think it's really important to know what imaging are needed and what are some of the pitfalls. So the ACR has adopted clinical practice guidelines for the appropriate use of imaging in the management of gastrointestinal bleeding. So endoscopy should be performed first in all instances of non-variceal upper GI bleed, unless there is some sort of contraindication. So endoscopic diagnosis successfully identifies the source of hemorrhage in up to 95% of cases, and at the same time can facilitate therapeutic hemostasis. There is variability of timing for endoscopy in the literature. However, the literature does support there are superior outcomes in terms of decreasing the length of hospitalization, rebleeding rates, transfusion requirements, and surgical interventions when early endoscopy is performed. That is within 24 hours of presentation after initial hemodynamic resuscitation. So according to the ACR appropriateness guidelines, imaging should be used when there are any contraindications to endoscopy. And the contraindications are usually trauma, and in the post-operative setting when the endoscopy did not find the source of bleeding. So conventional arteriography, so angiography, has the highest appropriateness rating. However, CT angiography is a comparable non-invasive alternative. CT enterography is the next best option for these patients with negative endoscopies. Then we also have tagged red blood cell radionuclide scanning, and these may be appropriate when there's slow bleeding, negative endoscopy, or no clear source of bleeding detected on CT. So we're now going to move on to lower GI bleed. So the management of a lower GI bleed is largely dependent on the patient's hemodynamic status after initial resuscitation. And the biggest limitation for a colonoscopy is a need for bowel preparation. So due to this, the ACR guidelines rate colonoscopy as an appropriate initial management tool only for hemodynamically stable patients who are able to undergo sufficient bowel preparation. So tagged red blood cell scans or CT angiography of the abdomen and pelvis are comparable first-line alternatives when colonoscopy cannot be performed. So tagged red blood cell scans are useful in the setting of a negative colonoscopy and when the bleeding is slow or intermittent. This modality, compared to the others, has the best sensitivity for slow bleeding. Colonoscopy yields superior diagnosis and hemostasis compared to conventional angiography. And angiography is usually for patients with severe gastrointestinal bleeding and are hemodynamically unstable. This is the alternative to surgery. So angiography is also appropriate in the patients with recurrent or persistent bleeding after colonoscopy hemostasis. There is superior diagnostic yield as well as decrease in morbidity and mortality when non-invasive imaging is performed prior to endoscopy, colonoscopy, conventional angiography, or surgery. So we actually play a very important part in the management and the outcomes of these patients. So surgical management is a definitive therapy, but it is usually reserved for emergent cases when the risk of exsanguination is very, very high. So this is a table showing how sensitive all the imaging techniques are. So for each modality, there is a threshold rate of bleeding that needs to occur before it can show up on imaging. And this is really important because even if you don't see bleeding on CT angiography, which needs a greater than 0.35 cc per minute flow rate, you may be able to see it on the tagged red blood cell scans because you need a slower rate as needed in order for it to show up. And conventional angiography actually requires the greatest flow rate, as in bleed rate, for it to be detected at greater than 1 cc per minute. But the good thing about conventional angiography is that it is orthotherapeutic and therapy can be performed at the same time, such as coiling and embolization. Now we're going to move on to CT. So CT is now widely and increasingly utilized in the evaluation for GI bleed. The reasons being it is universally available, it is readily accessible, and the images can be rapidly required, and it's actually very, very accurate with a sensitivity of 85.2 to 100%. Here are some of the advantages and disadvantages of CT. Firstly, it's able to localize the source of arterial or venous GI bleed. And this is very important because arterial bleeds can be embolized and venous bleeds cannot. So this completely changes management. And secondly, it's able to diagnose the underlying pathology that may be the cause of bleeding to direct further management. So you may not be able to see active bleed, but you may be able to see something that can be the cause of chronic, slow, and intermittent bleeding, such as a tumor. And the management of a tumor is completely different from just embolizing an artery. Thirdly, it can diagnose the causes of bleeding not within the GI tract. And this is important because bleeding that is not within the GI tract may be from a vascular lesion, it may be hemophilia, and we can be able to pick that up on CT. And lastly, CT can delineate the underlying vascular anatomy prior to embolization and characterize any anatomical variants. This will be very helpful to our interventional colleagues. But CT is not without disadvantages. And firstly, there's decreased sensitivity relative to radionuclide imaging because for CT, the rate of bleeding needs to be faster compared to the tagged red blood cell scans. There's a high radiation dose. So CT for GI bleeds needs to always be performed with all three phases. So that is essentially multiple CTs, thus increased radiation dose. There's a need for IV contrast, and this can be very difficult when the patient has poor or difficult IV access or have allergies to iodinated contrast. And lastly, false negatives can occur if patient is not bleeding at the time of the scan. So regardless of the modality, the patient needs to be bleeding at the time of the scan. So we'll move on to CT angiography of the abdomen and pelvis. So it is a multi-phase study. We need a non-contrast, arterial, and portal venous. You'll hear me repeat this throughout the lecture because this is how important I think this concept is, that we do need all three phases. So my motto in life is do it right and do it once. And it takes a lot of effort to get a patient to a scan, from scheduling, getting the patient in the room, IV access, IV contrast, etc. So we really should get it right the first time. Not only that, say for example, if you miss the non-contrast study, you cannot go back and scan the patient again if IV contrast has already been given. Similarly, you cannot just rescan the patient if you missed any of the timing, because when the timing is incorrect, it may lead to the wrong interpretation. So that study is basically not diagnostic and you've given the patient all this radiation. One cannot just simply re-inject IV contrast either, as you already have contrast on board and that will just muddy the water and impair interpretation. So this is actually our CT lower GI bleed protocol. So you can see we have a non-contrast, an arterial phase, and a portal venous study. And this is a second takeaway point. Do not give positive oral contrast. So the reason being, when you think about it, we are looking for intraluminal contrast extravasation, right? So that's going to be bright. It's iodinated material. So if you already have a positive bright stuff in the bowel, how can you tell what is oral contrast and what is extravasated IV contrast? You cannot. Therefore, do not give positive oral contrast. So some institutions have a coronal MIP, maximum intensity projection, for the arterial phase as well. And this can really help intensify the appearance of contrast extravasation. And I would like to make a mention about dual energy CT because it has become increasingly employed in the evaluation of gastrointestinal bleeding. Dual energy CT uses two different scanning voltages, one high, one low, usually 140 kVp and 80 kVp. Therefore, it can delineate between different substances and create an iodine map for us, obtained when IV contrast has been administered. Also, the ability to create a virtual non-contrast image can be very useful because that can decrease the number of phases that we are scanning and thus save radiation dose. So the iodine map basically looks a bit like the coronal MIP. So it intensifies the iodine to give us a better look and assessment of whether there's any contrast extravasation. The dual energy technique can basically utilizes a K edge of iodine, making iodine more conspicuous when evaluated with a low KVP or KEV. So let's move on to small bowel bleeding. And when endoscopy and colonoscopy are both negative, but the patient has persistent or recurrent GI bleed, presumed bleeding is from the small bowel. And I've had many conversations with clinicians, and this is a real clinical dilemma for them. A capsule endoscopy is a preferred technique. It has a diagnostic yield of 32 to 76, so quite variable and slightly low. The complete examination of the small bowel is achieved in 74% of patients. And capsule retention or surgical retrieval occurs in 1.9% of patients. There are some contraindications to capsule endoscopy. These include pacemakers, dysphagia, and suspected small bowel strictures, because then the capsule will get lodged and not pass, and then you have to retrieve it surgically. The other disadvantage is the long turnaround time and the large amount of images that need to be reviewed. And this makes it very unsuitable for the evaluation of acute severe small bowel bleed. So that's why CT enterography is really useful in these group of patients. So again, multi-phase study, I'll go through our protocol shortly, and neutral oral contrast agent is used. So it's the same neutral oral contrast that is used in the assessment of inflammatory bowel disease. And the idea is exactly the same, to distend the small bowel loops to evaluate the small bowel mucosa and look for contrast extravasation. And given the need of oral preparation, this is reserved for patients with suspected small bowel bleeding who are hemodynamically stable. And this is an important technique, not just for the localization of an active bleed, but also to assess for any underlying small bowel vascular lesions, as well as even inflammatory bowel disease, which can be a cause of bleeding. So this is our CT enterography protocol. So we have arterial, enteric, and delayed. And the neutral oral contrast that we use is volumen. So the imaging features of GI bleed on CT, there is highest sensitivity when you combine the findings from the arterial and venous phases. So arterial phase is typically the most useful for the evaluation of active bleeding, but sequential comparison of all phases offers best performance. So on arterial phase, it is very sensitive for contrast extravasation in acute hemorrhage. There's variable appearances that we see on CT, and we're looking for high density intraluminal contrast, greater than 19 Hounsfield units, and we're looking for linear extravasations. And linear extravasations may be confused with vessels because they all look linear, but it's very important to then look at the portal venous phase to see if it changes configuration. If it does, you can confidently interpret it as active bleed. So this is our first case. This is a 77-year-old patient who presented with decreased blood pressure and melena. So this is a CT in arterial phase, axial and coronal reformats. So firstly, we see a hyperdense clot. and which will look very, very closely. So the clots can be useful because this can be the telltale sign of where approximately a bleed is occurring. And then if we look closely right next to it, there is a focus of active circular bleed. This is a 45-year-old patient with a gastric pull-through, performed for history of esophageal carcinoma, presenting with hematemesis. So the CT angiogram axial image shows an area of active linear extravasation in the stomach. And then we can see there is pooling of contrast on the delayed phase in keeping with an active bleed. And this is what I meant by checking to see if it changes configuration. And when it does, you can definitively say that there is active bleed. So the venous phase is very valuable too. And this is a phase you want to look for slow or delayed bleeding, or bleeding from the portal venous system. This is an important phase to characterize bowel mucosal lesions or vascular malformations. You may not be able to see an active bleed, but with these entities that I talked about before, because they often cause chronic, slow, and intermittent bleeding, which is below the threshold of detection on non-invasive bleeding. But if you do see it, you can suggest this may be the etiology of what the patient is experiencing. So inflammatory bowel disease is a common cause for gastrointestinal bleeding. And like I said before, CT enterography is the modality of choice for this particular entity. So why do we need the non-contrast series then? Well, the non-contrast series is particularly useful in localizing hematomas, blood products, or anything that looks dense. This can also act as a clue as to where the site of active bleed is. So the initial unenhanced scan can also help delineate hyperdense structures that were already in the bowel, such as food, surgical clips, or retained contrast within a diverticula, or and then differentiate that from true active extravasation. And this reduces the probability of false positive misinterpretation. So here we have a case. This is a 54-year-old patient presenting with GI bleeding and decreased hematocrit. CT angiogram, axial images in arterial phase showed no contrast extravasation. However, on the portal venous phase, contrast extravasation and pooling was seen in keeping with a slow or delayed bleeding. So here we have a case. So this is a non-contrast axial image, and you can see there is this hyperdense material within the lumen. And one thing to keep in mind is that unclotted blood will measure between 30 to 45 Hounsfield units, and clotted blood will be more bright and will be 45 to 70 Hounsfield units. And you can always look for an sentinel clot if it is there, and that is actually the term used for a hematoma with the highest attenuation, seen closest to the site of bleeding. We're going to go through some of the different extravasation appearances on CT. So here we have a 37-year-old with acute upper GI bleed. And on the CT angiogram axial images, we see active linear contrast extravasation into the stomach on the arterial phase. And we can also see this on the portal venous phase. And there is a change in configuration. So we are certain that this is an area of active bleed. So this was confirmed on conventional angiography, and subsequently embolization was performed. Here is a case, a 56-year-old patient with hematocrit drop, and the arterial axial CT demonstrates a linear active bleed with a fluid clot level. So the clot sinks down because the hematocrit is heavier. So you'll see hyperdense material at the bottom layering. And on conventional angiography, we can see active bleed that was confirmed. This is a 61-year-old with GI bleeding with a history of a total pancreectomy and biliary stent procedure. So on initial CT angiogram, it was negative for active bleed. So that was performed at an outside institution. But on angiogram, it looks like there is a pseudoaneurysm of a branch of the left hepatic artery. So we're thinking, given the previous biliary stent procedure, there's likely a biliary fistula for the blood to track into the biliary system and subsequently into the second part of the duodenum. And on the portal venous phase, I know this is not an arterial phase, not perfect, but on the portal venous phase, in retrospect, maybe there was a small pseudoaneurysm in this location. This is a 51-year-old patient with GI bleed, which was unable to be located on upper and lower GI scopes. So post-contrast arterial phase axial CT demonstrates active, looks cloud-like bleed in the hepatic flexure. This is a 76-year-old patient with acute on chronic bleeding. Post-contrast arterial phase CT demonstrates active linear bleeding from the rectum. This is a 47-year-old patient with acute on chronic bleed. So we have a few phases here. Firstly, on the non-contrast study, we can see there's something hyperdense within the mid small bowel lumen, and this is in keeping with the clot. So next we look at the arterial phase. So around where the clot is, we don't really see any contrast extravasation. However, we see another at this same spot on the portal venous phase, we do see some contrast extravasation. So this is in keeping with an active bleed. And this bleed may either be venous, because we're seeing it only on the portal venous phase, or it could be very slow. So there is actually another focus of active bleed that's more distal to the above mentioned location. And if we go back to our arterial study, it's actually located in the distal small bowel with active linear arterial bleeding. So the moral of this particular case is be very cautious of satisfaction of search, because in these patients, there may be other areas of bleeding, or there may be other causes that could be potential etiologies for GI bleed. We'll go through some entities now that often cause chronic, slow, and intermittent bleeding, which can be below the threshold of detection on non-invasive imaging. It doesn't mean that they're not important, it just means that the management will be different. So firstly, we have a 57-year-old patient with rectal bleeding. And this is a CT angiogram axial image, and it demonstrates a large enhancing right anal/rectal mass. And we do not see any active bleed on CT. This is a 42-year-old patient with melena and abdominal pain. So previously I was talking about dual energy CT. So this was actually performed with dual energy CT for suspicion of a small bowel mass. And here we see on the axial post-contrast CT, there's an enhancing mass that we can see. And the loops proximal to the lesion are all dilated. So this lesion is probably causing some sort of mechanical small bowel obstruction. And the next image I'm going to show you, I'm sorry, this is a distal loops being collapsed, so confirming that there's some sort of obstruction that is happening. So this is actually a dual energy CT iodine map. Can you see how all the iodine really lights up and is very, very conspicuous? And you can see this mass was better visualized on the iodine-only images from the dual energy CT. And this is how dual energy can actually be very, very useful. And this ended up being a small bowel carcinoid. This is a 65-year-old patient presenting with anemia. So post-contrast CT axial images and sagittal reformat shows a mass within the rectum. And this is suspicious for rectal adenocarcinoma. And this was the etiology for the patient's symptoms. Now we'll move on to some other vascular causes. This is a 32-year-old patient with severe hematemesis and hypotension. The CT angiogram shows a small pseudoaneurysm arising from a branch of the splenic artery. And this was also seen on the conventional angiography. It was subsequently embolized. So this was deemed as the source of the patient's upper GI bleed. This is a 57-year-old patient with hepatitis C and liver cirrhosis, presenting with acute GI bleed. The CT angiogram demonstrates very large varices in the stomach wall. There's no active bleed that we can see on CT, and the varices are much more prominent in the portal venous phase. These large gastric varices were the source of the patient's GI bleed. There are also infective and infectious/inflammatory causes for GI bleed. So this is a 60-year-old patient with known myeloma and new complaints of fever with abdominal pain and GI bleed. Post-contrast CT, axial and sagittal reformats show this diffuse thickening in the rectum and sigmoid colon with a comb sign in the adjacent mesentery. And this is suggestive of active inflammation. The patient was diagnosed with infectious colitis, which was suggested to be the etiology of the patient's lower GI bleed. So now we've gone through some cases, we're going to actually visit some pitfalls, because I think it's very important to know not just the limitations of our imaging, but also some of the pitfalls to avoid so we don't make any misinterpretations. So firstly, the nature of bleeding, severity, rate, and intermittence. As we said before, the rate is very, very important because each modality has a different threshold for how fast the blood must be gushing out for us to pick it up on imaging. There are some patient factors such as hemodynamic status. So what is a patient's output? And is it adequate to see extravasation? The patient's BMI, body mass index, and as we all know, the bigger the patient, the worse the images with attenuation of the photons. And this can really limit what we can see. Pre-existing intestinal contents is a very big pitfall, and that's why we do not give positive oral contrast. And also hyperdense foods can obscure intraluminal contrast extravasation. Other factors such as CT technique, how are we protocoling these exams? Again, we need all phases in order to successfully diagnose active GI bleed. And we want to know what the iodine concentration of the contrast is. because if it's very dilute, we won't be able to see it very well. And in terms of dilution, it could be dilution of contrast in a fluid-filled bowel loop. And then so we don't see that gush of the blush of contrast that we are trying to look for. Inadequate bowel distension can really make it difficult to not just see tumors or inflammatory lesions. You can't really see that intraluminal extravasation very well. So we're going to go through some pitfall cases now. This is a 30-year-old patient with GI bleed, previous resection, secondary to vasculitis. So contrast-enhanced CT demonstrates oral contrast, positive oral contrast, and they're also suture materials. And these two things really obscure the intraluminal space and limits us to see extravasation of IV contrast. Hence, the patient subsequently went on to a different modality. And there are actually areas of active bleed on conventional angiography, as well as on the nuclear medicine tagged RBC scan. This is a 71-year-old patient with a hematocrit drop. And post-contrast axial CT demonstrates a gastric mass with kind of hyperdense foci adjacent to it, but we don't know whether this is active arterial bleed because the patient was given positive oral contrast. And therefore, we couldn't definitively diagnose it as active bleed. There is a contrast fluid level, and this may either be due to extravasated IV contrast or trapped oral contrast. This is a 71-year-old patient with GI bleed, previous bowel surgery in the jejunum. CT angiogram was negative for active bleed. But there's a lack of bowel distension, and that may potentially have obscured IV contrast extravasation. Actually, active bleed was seen in the right upper quadrant on the nuclear medicine study, and active bleed was confirmed adjacent to the suture material on conventional angiography. So the suture material likely obscured the bleed on the initial CT. Lastly, we're going to move on to nuclear medicine because this is the last of our non-invasive imaging. It's actually one of the earliest reported methods of detecting GI bleed. It was described in 1977. I'm sure many of you were not even born then. And it is the most sensitive non-invasive technique, and it can detect rates as slow as 0.1 cc per second. So how do we do it? So traditionally it was done with technetium 99M sulfur colloid, but it was replaced by red blood cells because of the limitations from overlying liver and spleen uptake with technetium 99 sulfur colloid scans. And the advantage is high sensitivity. Again, the patient has to be actively bleeding at the time, and there can be localization issues. However, I have found that localization of the bleed can be markedly improved with the use of SPECT. This is actually becoming one of my favorite modalities for GI bleed because a lot of times you just do not see the slow intermittent bleed on CT. This is a 67-year-old patient with gastrointestinal bleed while on anticoagulation therapy. And this planar scintigraphy demonstrates accumulation of radiotracer in the cecum, in keeping with cecal hemorrhage. The CT angiogram and conventional angiogram were performed externally and were all negative. And this case really illustrates the superior sensitivity of nuclear medicine tagged with RBC scans for slow GI bleed. This is a 50-year-old patient with gastrointestinal bleeding. So on contrast-enhanced CT, we see positive oral contrast, my pet hate, from a prior CT that obscures the active bleed, which we actually see on the tagged red blood cell scan and on conventional angiography. This is a very interesting case. This was a patient who was post-embolization, but their hemoglobin was still dropping and they just could not find a source of bleeding. And this again demonstrates the power of the tagged red blood cell scan. On planar image, we can see that there's radiotracer uptake in the left hemiabdomen. Then we have SPECT, like what I was saying before. SPECT really helps us localize where this bleed is coming from. And the radiotracer uptake is right there. And it is right next to where the embolization coils are. So it's probably rebled. Embolization coils right next to it. So conventional angiography, I'm not really going to go into this because this is not really non-invasive imaging, but it is the least sensitive of all the imaging techniques that we went through. You need greater than 1 cc per minute bleed rate, but it is very, very useful in therapeutic interventions. So this is the next thing to go to after we have found a bleed. So in conclusion, CT angiography is a good first-line modality for the detection of GI bleed. There are limitations to nuclear medicine, CT angiography, and conventional angiography, and we need to know what they are in order to avoid them. Contrast extravasation indicates active bleeding can occur in either or both arterial and venous phases. It is important to identify pitfalls when interpreting a negative CT angiography. And intermittent bleeding can be common, and there are a myriad of causes, and we should look very hard for them on CT. Thank you very much.
Thank you very much, Dr. Wang. It was a wonderful presentation and it was very educative and I thoroughly enjoyed it. We have a couple of questions from our audiences, so I would like to speak for you. So our first question is, can we directly do CT angiography instead of endoscopy or colonoscopy?
Yes, we definitely can. I understand that different institutions and different resources are available to us, and CT angiogram is definitely something that is now considered first line.
Another question is, what CT slice is capable of CT enterography?
I'm not sure what you mean by CT slice, but all the machines should be able to obtain a CT enterography. The important thing with CT enterography is really the prep with the neutral oral contrast.
Okay, wonderful. Thank you very much for answering, Dr. Wang. I also want to let you know that we have our participants from across the world. We have almost like 130 attendees right now. I guess we have another question. So just with bleeding, CT versus MRI for the sensitivity to pick up bleeding. Okay, maybe that's so. Yeah, so you're getting greetings from Bhutan, Dr. Nidup, Dr. Pradhan, from Ethiopia, Dr. Gitane, Dr. Maniro from Mexico, Dr. Neka from Nigeria, Dr. Fatia from Kenya, Dr. Taslike from Turkey, Dr. Sebastian from Burundi, and Dr. Shimbi from Zambia. So everyone is sending you greetings and they're very grateful to you for such a wonderful presentation. And we are very grateful to you to helping us doing this and spreading, helping us spreading medical education across the world. Um, to our audiences, I just want to let you know that we'll have this presentation available on our YouTube channel as well after a few days. So please feel free to check out. And thank you very much once again, Dr. Wang, for doing this. And we are grateful to have you here with us. To our audiences, thank you very much for joining today. And we look forward to seeing you all on our next international grand rounds.
Thank you all for having me. I'm just going to answer that last question with regards to GIST and bleeding, CT versus MR. So CT will be better than MR in terms of picking up GI bleeding. Hence, I didn't really talk about MR at all. For a few reasons. MR is difficult to schedule in. Not everyone has this resource. MR requires a long time for acquisition. So in the acute setting, you probably don't want the patient lying in your MR machine in your department for long periods of time if they have a likelihood of bleeding a lot. And in terms of MR is like a slower acquisition. So in my mind, I know there hasn't really been studies on this. I think you'll probably need, it will not be able to pick up that quick extravasation of contrast. So CT is definitely your modality workhorse for the evaluation for any type of question mark active bleed scenario.
Wonderful. I guess we have another question. So, what value do you give to MIP images?
I love the MIP images, especially the coronal MIPs. You can really see that little blush that is not so evident on your axial thin slices. And I find that it really does add value. By the same token, the coronal MIP images can add value when you're looking for inflammatory bowel disease on your CT enterographies. It just makes that enhancement a little bit more conspicuous to the eye. And for me, I feel it's very helpful.
Thank you very much. Thank you, Dr. Wong. It was awesome. So, thank you very much. And thank you to all the participants for joining us. And have a good one, everyone.
Thank you, everyone. Have a nice day.
You
Bye.
too. Thanks. Bye.